of my picture tiles. Oh, hold on a second, I want to get that out of the way. All right, so today I'm talking to you guys about acute pain in the setting of opioid use disorder. Last time we got together, we had a wonderful lecture from Matteo Caffrey about chronic pain and opioid use disorder, and he did touch on acute pain during that lecture. So in some ways, this is very much a review of what he already shared with us, but there are some other points that I bring forward and we get to maybe pay a little bit more attention to today since we're focusing on acute pain. So basically today, after we have finished this lecture, I want you all to feel more familiar with non-pharmacological options to manage acute pain in general, but also that are useful in our patients with opioid use disorder, and then how to utilize buprenorphine as an analgesic, because it is, after all, an opioid, and then knowing the approaches to managing acute pain in the setting of having a patient who takes buprenorphine or naltrexone. So pain is something that all of our patients, no matter what, are going to experience. Some of it will be acute pain that may turn into a chronic pain picture. Some of it is just acute pain. So whether we're providing opioid use disorder care, we're providing general care, we're providing pediatric care, whatever it is we're doing, patients are going to experience pain. And having a way to address that pain for our patients is incredibly important, considering part of our opioid epidemic is related to how we've managed pain in the past with gobs of opioids. So recognizing the fact that we are actually very intelligent, ingenuitive people, and there are more ways to manage pain than opioids, including ways that don't even require a prescription or a pill bottle. So some non-pharmacologic ways to manage pain. And it's one of those, like, you take a step back and you're like, oh, yeah, that's exactly what you do. Like, I twisted my ankle and it hurts and I go to the ER and I don't need, because I want to make certain I didn't break it, right, when I twisted it because I stepped in a gopher hole. And instead of giving me gobs of Lortab that I don't need, maybe they can just put a nice ACE bandage on it for compression to help stabilize that twisted ankle, or maybe a brace that has a little bit of rigid support built into it so it strengthens that joint a bit in the acute setting. I need to elevate it, maybe I need to ice it or put some heat on it. So there are many ways that we can address acute pain that do not require any medications at all. Sometimes for acute injuries, some physical therapy would be useful. So referring our patients into that, remembering that modality, massage therapy, exercise. Oftentimes people will have in their minds that they have, like, it hurts. I have tight muscles, I can't move, I can't bend, I can't stretch, I've got back pain. That people tend to be more resistant to change. Like, one of the ones that I will see often is when people will get that tight pain in their neck and they're like, I just can't move my neck. I'm like, actually, that's what you need to do to make the pain better. So getting people to engage in exercise. So doing some stretching, warming up those muscles, fixing. So sometimes, you know, if you've got a fracture, you need to actually control the pain. You need to have that fracture set. So you have to repair what may be causing the pain. Someone who's got a rotator cuff tear and they need to have an orthopedic surgery to address that pain. So there's an underlying cause. That's what we're trying to get at. We're not just trying to put medicine on top of it so we ignore the pain, because pain is a message that our body is sending to us that something needs to be addressed. So getting that addressed in a way that we can get to the root cause of the pain. It's one of the things that we don't need to forget. Acupuncture is a really great way to manage pain. One of the little pictures on here, the one with the ear with the needles in it, that's actually a demonstration of what they call battlefield acupuncture, where, and they use this in the military. And when we're done with the lecture, I actually will ask Skylar to talk a little bit about this, because he actually knows how to do this, if my memory is correct. So if you're in a situation where, say, you're a soldier and you get injured on the battlefield, this is a way to manage your pain until they can get you to a medical setting. So there are lots of different ways to address pain other than using opioids, and beyond that, using non-pharmacologic means. Mindfulness, meditation, and counseling are all ways to help people manage pain. In the chronic pain setting, if you have someone with chronic pain who's not engaged with, ever, is not currently engaged with nor has it been brought up to them that they should consider seeing a counselor. I advise very strongly to connect someone to a provider of behavioral health services. But it's also useful in the acute pain setting. So someone who maybe had an injury related to an unwanted, what traumatic event is wanted, but say it's the result of intimate partner violence, and they've had an acute injury related to that, that individual is definitely in need of counseling services. So talking to your patients about like how did we come to have the pain that we're experiencing, getting to know and understand the setting in which that occurred. Because a lot of those acute injuries that have some rather negative context to them can often turn into the chronic pain as well. So pharmacologic non-opioid pain management strategies, things like our ibuprofen, the non-steroidal anti-inflammatory drugs, so all the NSAID classes drugs, like the meloxicam. Acetaminophen is another one that can help. Scheduling acetaminophen really helps with pain. Topicals, such as diclofenac, which is an NSAID. So you're kind of putting the medication right where the pain is, instead of having to take something that's systemic, like the ibuprofen or the Tylenol. Baclofen, there are a couple of muscle relaxants that I really like to use. Baclofen, tizanidine are the two I tend to gravitate towards. Cyclobenzaprine just seems to be a medicine that makes people go to sleep. I try to stay away from that one. Because when I use a pharmaceutical, I like to use it for a purpose. Like I know what this is doing and how this is going to help, because my root cause, your pain source is, say, a tight muscle. You're having muscle spasms in the low back, and something like baclofen would be helpful in that situation because it's an antispasmodic as compared to cyclobenzaprine, which is just melt your butter, or Flexeril, cyclobenzaprine or Flexeril, which is, for me, it seems like it just makes people feel very sleepy, just kind of melted, like butter on a hot stove. But baclofen, although it can sedate people, it does also help relax that muscle as well. Lidocaine, whether it's a cream or as a patch to get at pain, somebody who's got costochondritis, they've had an injury to a rib, that's a pain that can really take a while to go away. Lidocaine patches are a great way to address that. CBD, guys notice the lovely picture in the upper right corner. It's a very pretty picture of some rather illicit looking substances. But if we're thinking about hemp or CBD and using that as a topical or a tincture, can also help some with pain. There's some, I didn't pull up a picture of this one, but arnica is another homeopathic medication that really helps with swelling and bruising. So there are a number of things out there that we can use because again, we are intelligent people who, if we stop and quit thinking about opioids, there are a lot of different ways to address people's pain, including compounding pharmacies. This is kind of a fun, way to go about medicine. It feels like, I don't know, it's 1843 and I'm actually thinking about what it is that I'm putting in my patient or on my patient. Medicine Shop is a compounding pharmacy and it is a chain, so there may be one near you. They have compounding pharmacists. So you can call and talk with them about, this is what my patient's experiencing. I think a little bit of this and a little bit of that may be helpful. They can give you some advice as far as they have swelling, they have an aching pain, they have more of a neuropathic pain. You can get gabapentin put into a cream. You can get obviously NSAIDs because there's a manufactured by the pharmaceutical companies already in a tube option for that with the diclofenac gel. Or the Voltaren, and you guys may have seen that in the pharmacy because it's now available without a prescription. You can get amitriptyline in a compounded cream. You can get lidocaine, bupivacaine. You can get so many different things, and all of those together, if you want, in a cream by talking to your friendly compounding pharmacist. So there are many different ways to address the pain that our patients are experiencing without having to go to opioids. So some of the ways of handling those medications, as I mentioned before, scheduling the acetaminophen, just set, you're going to take 500 milligrams 3 times a day of acetaminophen, and then you've got a little bit of extra for anything breakthrough. You can use ibuprofen, diclofenac orally, naproxen, those types of things, the systemic non-steroidal anti-inflammatory drugs. on a scheduled pattern. Again, whenever we schedule medications, we want to make certain that we are not exceeding the maximum allowable amount in 24 hours. So when it comes to acetaminophen, if we're also prescribing some Lortab, hydrocodone, Percocet, which is oxycodone, and acetaminophen, that you take that acetaminophen into account and you're not writing in excess of the amount of acetaminophen you want them to have in 24 hours. Gabapentin, using that one, especially if it's a neuropathic type of pain. Those topicals that I was mentioning earlier, the lidocaine, diclofenac, and compounded creams. Other things that you could consider. So these, some of these are definitely not going to happen in your office, such as nerve blocks, ketamine, and propofol. But say you've got a patient who had an acute injury of they were playing around on the monkey bars with their kid because they're doing great in treatment. They're have visitation with their kids or full custody with their kids. They took them out to the park, having a wonderful family moment, playing on the monkey bars, and dad acutely dislocates his shoulder and has to go to the ER. Really great way to take care of that is to give him propofol and put it back in place. And then he can get some acetaminophen and ibuprofen to take care of the pain from having a joint out of place and then put back into place. Nerve blocks, so maybe he fell off the monkey bars and he ended up fracturing his radius. They could actually do a nerve block for that arm and not have to use opioids at all, because they can use that nerve block to help control his pain, help get him through the surgery if he needed to have it pinned or something. So there are many different ways. We have many more tools than just utilizing opioids and all the different ways in which they are available. However, there are times when a short-acting opioid is the appropriate thing to use in that setting of pain. So for that patient that did have the broken radius and they did have surgery to pin it back, maybe 2-3 days of opioids following that surgery would not be inappropriate. So it's being mindful of the situation and prescribing appropriately. So like I mentioned, the guy on monkey bars that maybe broke his arm, he's your patient. He's in treatment, he's been stable, he's on buprenorphine. How do we manage pain acutely in individuals who are on buprenorphine? Because we know that is a partial mu agonist that binds very strongly to the receptor, to that mu receptor. And putting any other type of opioids in this individual could potentially be a trigger. It may not even work. You may have to use large doses to actually get any effect from that short-acting opioid, or even a long-acting opioid if you needed to use that for, although I'm not certain you wouldn't need to use that, but putting opioids back into the picture on a patient who has buprenorphine in their system already does pose some challenges. So just as I've already mentioned, we're going to try all the other things that are at hand, such as non-pharmacologic interventions, non-opioid pharmacologics, continuing the same buprenorphine dose, not changing it at all, and adding some of those non-opioid medications on for analgesia. You can also increase your patient's buprenorphine dose and split the dose, because buprenorphine does have analgesic properties. They last for about 4 hours, which is why you want to divide the dose to get the most out of that analgesic property that it does have. So splitting it up 3 times a day, 4 times a day, and possibly bumping the dose up a little bit when you do that. Even just dividing someone's current buprenorphine dose, they're going to get some analgesic benefit from that. Depending on the situation, though, you may want to increase your patient's dose and split it. Another method people will use is, especially if they've got a planned surgery for their patient coming up, they will stop the buprenorphine a few days before the surgery and initiate full agonist therapy. So say I don't, and as you can see in the parentheses, like this is not my go-to. I don't prefer this choice at all. There may be situations when this is what is appropriate, depending on the patient, depending on the situation. I've done this once with a patient and it was not a good experience for her or me. And I have not yet had another situation come up where I felt like it would be a good choice for my patient or the situation. So in the one time that we did it, I had her stop her buprenorphine a few days before her surgery. And then after surgery, she had Percocet to manage her post-op pain. And then the plan, which did not go according to plan, because it's not a plan that I like anymore, and this is the reason why. She was the amount of time it took her to end up back in my clinic, she'd been continued on the Percocet way longer than she needed to be. The Percocet dose actually to help manage her pain was not quite enough because she was not opioid naive, so the dose was a little low, and she was also having withdrawal on top of that. So her pain was not well controlled, and she was experiencing withdrawal. So when we got her transition back to the buprenorphine, things settled down and it was fine, and we both vowed to not do that again because she was having a series of surgeries done. So we knew there was another surgery coming up, and we went about it a very different way the next time. And she had a much better experience with her surgery. But one of the things that happens when you stop it, you do the full agonist, you taper them down off of that, and then you're reinitiating the buprenorphine. There's just a lot of switching back and forth, initiating. There are just so many places and ways that could go wrong that I really don't advocate for that choice. Again, there may be a situation that presents itself that you need to do it that way, but since that one patient experience, I've not had another one. So the analgesic property of buprenorphine, basically it hits the system in about 30 to 60 minutes, and then you see the peak clinical effects 1 to 4 hours after that dosing. It can last for up to 12 hours at lower doses, and you're going to get more lingering about in the system at higher doses. So the half-life of buprenorphine anyway is about 72 hours, is about 36 hours. So it's about a day and a half. But watching someone when they've stopped buprenorphine acutely, it's usually around day 3 that you start to see them really having definite physical withdrawal, which isn't to say anything about the psychological withdrawal. That's a whole different entity, because that can happen 2 hours past the time that they normally take their buprenorphine. But to get that analgesic property and utilize it, manipulate it to our and our patients' benefit, I'll usually dose the medication anywhere from 4 to 6 hours when I'm splitting the buprenorphine to get that analgesic effect. Just simply because that's the way that it works. When it goes into the system, when you get the peak effects, and then when it starts to sort of, that peak effect begins to wane. It's interesting that it does it at lower doses instead of higher doses. That's a little bit kind of flip the way you think about it. Like 200 milligrams of ibuprofen isn't going to touch this. 600 milligrams of ibuprofen will. When it comes to using buprenorphine for the analgesic effects, the lower dose is more effective in providing the analgesia. So it's a little counterintuitive. So she's having surgery, this patient on buprenorphine of yours. And so the ways in which we want to approach this surgery, so sometimes surgery just happens and you find out about it after the fact because it was an emergency surgery, or maybe you don't find out about it even though it was a planned surgery until they're at the pharmacy trying to fill their Percocet prescription. But what you want to do pre-op, ideally, is get all the consent in place so you can have an open conversation with any other providers who are going to be interacting with your patient around that surgery. So whether it's the surgeon, the anesthesiologist, anybody else that may need to be part of the care team for this patient around the procedure that they're going to be having. Have your patient talk to their surgeon and the anesthesiologist when they have that interview that they are on buprenorphine, methadone, naltrexone, whatever medication it is that they're taking, because that surgeon needs to know. A lot of patients are reluctant because they're like, and I'm going to tell them that, and they're going to start treating me differently. And so the stigma that comes with, I'm on this medication and I have this condition. But it can really impact some of the choices that are made for the surgery by the anesthesiologist, by the surgeon. So having your patients talk to the surgeon about the medication that they take is incredibly important. And then backing that up, like, I know you're nervous talking to your surgeon about being on this medicine, but in that same conversation, I want you to tell them, here's my number, please call me. This is the person who provides my buprenorphine, my naltrexone, whatever, and they would like to be part of the planning for post-op pain management. So it's that conversation that your patient's having with their surgical providers that can invite, and they want to talk to you, and they want to support what's happening with my surgery. They are involved, they are engaged. I've had some really fun conversations with surgeons because we start off and they're a little uncertain, and I'm like, because I want to help with the post-op pain management. Oh, okay. Like all of a sudden, like all the pretense is gone. There's tons of relaxation. It's like, I'm on this team. I want to help you. And the fact that they don't have to sweat it through, like, am I going to be asked for opioid prescriptions, 2 weeks after surgery from this patient? Nope. There's somebody there who wants to help out and who's willing to manage this patient's pain, who knows them possibly better than I do, and is involved in their care. So being available to talk to that surgeon and being willing to participate in the post-op pain management is it's huge, because it also provides a level of support to your patient that they know that that you're there for them. So the title of this slide is kind of fun for me, because these are some of the surgeries that I've gotten patients through, managing their buprenorphine and maybe a little bit of short-acting opioids. Actually, the one for open heart surgery, Dr. Riskina, who's on this call, she had a patient, that was her patient, with open heart surgery that she managed to get through his post-operative course of having his chest cracked open by increasing his buprenorphine dose and dividing it. He was also on short-acting opioids for a little while, but those were gone actually within a week, I think, of his surgery. And that's not a small surgery. That's one of those high-risk type of surgeries, and it's very painful. And he actually did really, really well with Dr. Riskina's care. So it's actually pretty amazing what you can do just by manipulating the buprenorphine. In this particular case with open heart surgery, he was titrated back down to his original buprenorphine dose. That took a little longer. Again, that's a surgery when you think about it. It's not like having, I don't know, a C-section, although that one hurts as well. That's an abdominal surgery. But typically within a week or so, you're kind of like, yeah, it's a little sore, but you're cruising on. But having your chest cracked open, that took a little bit longer for him to feel as though the pain was to a point that we could start going down on the buprenorphine dose. If opioids are going to be part of that pain management picture for your patient, talk to them about the medication choices. So, you've got some options, because for a while there we were cranking out all kinds of, we still are, different types of opioid formulations. So if morphine is something that they used to use in the past, and being around the morphine, it may be a little not very safe feeling for your patient, maybe oxycodone is a better choice, or oxycodone is really not a good choice for your patient, because that's the one that they were snorting before they came to see you. So having that conversation with your patient of, we have options, which ones feel the most safe to you, is going to be important, because the last thing you want to do is put your patient in a situation where they're potentially triggered to return to use. Pain in and of itself is a trigger for returning to use, and then being exposed to what you used to use is definitely a trigger for return to use. But we've been talking about opioids. What about that blocker? We have so many patients, sometimes we forget, no, it's not that patient, it's this patient. I know we all do a good job keeping track of our patients, but sometimes we forget which medicines they're on. And this particular patient is going to have surgery, and she takes naltrexone. It's a shot. She gets the extended release naltrexone, and her surgery, oops, what is that? Not what I want. What did I do? There we go. And she's having surgery in 2 weeks. So we definitely need to think about our post-op pain management options in this patient, because she's now has naltrexone in her system, which will block any of the opioids that she might get. So again, mild pain, we can look at our non-opioid options. Elective surgery, we get to plan it. So knowing that she maybe had her shot 2 weeks ago and she's getting surgery in another 2 weeks, then we hold her next shot and we can treat her pain accordingly after she's had her elective surgery. Oral naltrexone, if she was taking pills, then it's a matter of about 3 days that we need to hold the medication for, in order for there to be enough of those mu receptors available to receive any of the opioid pain medications the patient may need after surgery. Major pain or an emergency surgery, again, we have lots of options. Regional anesthesia, so doing those nerve blocks. Depending on what type of surgery it is, someone may end up with an epidural, and so we're blocking it, the like for like a C-section from the legs down. And then once the epidural wears off, we're in a place where we can manage it with ibuprofen and Tylenol, and we don't need opioids on board. Conscious sedation, like I mentioned earlier with the propofol for the guy who had the dislocated shoulder, that's conscious sedation. So if you need to do a procedure that's painful, but it's quick, you can use some of those medications to help in that situation. And then general anesthesia. Obviously, if you're having major surgery, they're going to put you under. You can use some high potency opioids like fentanyl to override the blockade. If you are having to use high potency opioids, I would recommend having your patient in the ICU, just because, especially with naltrexone on board, and you're trying to override that blockade, the potential of, you know, the balance between overriding the blockade and pushing past that and actually ended up in an overdose picture, they need to be watched a little more closely. So an ICU setting where they've got maybe a little bit closer to one-on-one monitoring, and they've got all of the appropriate monitors in place that are on a very short cord connected to nursing staff that can respond immediately. So there are some opioid medications that I would advise avoiding in opioid dependent patients. We use Stadol and Nubane with some frequency on our labor and delivery unit. I came across Nubane in the ER because I'd have to borrow it sometimes for labor and delivery. I'd have to go down to the ER and go back up the hall with a little vial of Nubane in my hand. But in patients who are opioid dependent, stay away from these two guys. I don't know that they're used all that much anymore, to be honest, but if they are still in your facility and your patient is on buprenorphine or methadone, do not use them, as they can precipitate a withdrawal. The way that these two are made, and I think it's determined, it's done this way for abuse deterrent, is it's an agonist-antagonist action at the mu receptor. So it kind of like attaches and then blocks itself. I don't really know how they work, but I just know that we don't want to use them in those opioid dependent patients because of that potential to withdraw them. And that, friends, gets us to the end of my lecture. What questions might you have? I'm just going to go ahead and stop my share. Even though it's a pretty picture, I'm going to stop my share, guys. All right. Oh, there's one here. Oh, this is Rick. I thought that was somebody's name. I'm like, oh, someone else has joined us. That's a note from Rick. He just shared an article with us in the chat, and systemic lidocaine, ketamine, and acute pain management. So there's a lovely article there that he's attached for us. Thank you, Rick, for doing that. And then Skylar, did you want to share a couple of words about the using the auricular acupuncture?
Yeah, sure. Can I share my screen? Is that? Let me see.
Maybe able to.
See if I can. Let me see. Just a moment. Gotta get this up.
While he's pulling that up, Rebecca, do you want to go ahead and introduce yourself? If you'll unmute for us. And
hey.
Hi.
My name's Rebecca Maloney. I'm a fourth-year pharmacy student. I'm on rotation with Dr. Toole at ETSU Family Medicine this month. I was just popping in. I'm really interested in psychiatric pharmacy and pain management. So I was just sitting in on your lecture. Thank you so much. It was super interesting to hear about managing pain with buprenorphine. That was something that I hadn't really seen much before now. So thank you. It's great.
Great. I'm glad you joined us, Rebecca. And now I recognize this part of you. You've been in the whole garb. I've seen you in clinic this morning. So thank you for joining us.
Thank you.
All right. Skylar shared some pictures with us.
Yes, this is the battlefield acupuncture protocols that we've used in training medics, combat medics on the field. These 5 points, particularly Shen Men, which is this one right here, have been associated with some generalized pain relief without sedation, and the lack of need to remove the soldier's helmet is particularly important because they might have neck injuries, but also just for protection on the battlefield. And also occasionally you still need them to be able to operate their weapon as the unfortunate conditions that sometimes are met. But this is what we've trained our battlefield medics in the Air Force to utilize, and my understanding is that this has also been distributed out into the U.S. Army as well.
Great, thank you for sharing that, Skylar. It's actually something that you can do in clinic for patients who are experiencing pain as well. So it's another potential tool in our belts to help patients with acute pain. Simona had a question about post-operative pain in patients who are on Sublocade, and I think we don't get the chance to increase the dose or divide it in that situation. So I think using your short-acting opioids and non-opioid medications would be an option. And I don't know about the potential of adding some low-dose buprenorphine sublingually. That's something to look into. It's not something I've heard of, but I could see it as a potential. So we can look into that a little bit further. Because of the time, I'm going to go ahead and get Dave Onyabe to go ahead and share his case with us. Because like I said, I promise you guys I can talk. I only had 17 slides. I don't know how I